Thank you so much, Dr. Monaco. And I just want to thank everyone for taking time out of their day to listen to a topic that I'm very passionate about and very excited about. And it's entitled The Future is Here. And I hope that by the end of the presentation, you understand why I'm saying that the future is here. And we are, of course, talking about neuromodulation and how we can use the gate control theory to our advantage. And again, I'm Dr. Joseph Liao. I'm an anesthesiologist and the chief pain fellow here at Stanford. So do you know of anyone who has any of the following items? A hearing aid, pacemaker, defibrillator, insulin pump, or any sort of hardware? And we'll come back to this question again at the end of the presentation and why this is pertinent. And another two questions I have for you are, what do you do when you get a mosquito bite? And what about when you stub your toe? And we'll come back to this later as well. Let's talk general pain statistics. Per the CDC in 2021, 1 in 5 US adults suffer from chronic pain, which is pain that lasts greater than 3 months. That's approximately 20% of the population, or 51 million US adults. 7% of the US population experience high-impact chronic pain, and high-impact chronic pain is pain that causes substantial restriction to daily activities. So that is a high figure. So what is pain? Are we just a bundle of nerves where we're comprised of the brain and the spinal cord to make up the central nervous systems, and we just have peripheral nerves branch out? And here is an image of an actual dissection of a human with all the nerve endings left over. Well, it's really more complex than that. We're not just a bundle of nerves. We're a compilation of all of our life experiences and everything we've been through. And the IESP definition of pain is an unpleasant sensory and emotional experience associated with or resembling that associated with actual or potential tissue damage. So it means that it's a dynamic interplay of our past physical and emotional experiences. So why is this important? Or let me challenge you with this. Why is it beneficial? Well, given that's an unpleasant sensory and emotional experience, the complexity and the multifaceted nature of pain actually allows us to manage pain through psychological, physiological, pharmacological, and anatomical modalities. So because there are so many layers to this, we actually have multiple layers we can try to target to help someone manage their pain on a day-to-day basis. And what is the point of acute pain, which is separate from chronic pain? Well, pain can be helpful in detecting tissue damage. And this also helps drive behavioral changes, which is essential for survival. And this is a normal pain pathway. So when we feel any sort of nociceptive input or undesirable input, the sensory changes causes propagation along the peripheral nerve to the dorsal root ganglia to the spinal cord, which then leads to it traveling up to the brain and then to the higher functioning and processing centers of the brain. And what is chronic pain? Well, it's really when the normal pain conduction pathways become abnormal and the input becomes processed incorrectly along the pathway, even in the absence of an underlying sinister cause. And as such, we can actually target this abnormal conduction pathway at different areas. And this is an image I want everyone here to get well acquainted with. It's what I like to call the 4 P's of comprehensive pain, or at Stanford, what we call the 4 legs of a chair. And this is really talking about the treatment options in how we address chronic pain. The first P is physical therapy, psychology, procedures, and pharmaceuticals. And I'm not saying that any of these are more important than the other. They have to use in collaboration because every single leg is crucial for long-term stability. So I'm sure many of the listeners here have tried multiple classes of medications. Perhaps they've tried different types of physical therapy or different types of procedures or different pain psychology techniques. And so a question that I find myself asking is, are we using all the tools in our toolbox? Well, I also want to challenge you with this. Perhaps the right question is, are we using the right tools for the right job in the right way? And I absolutely love this image we have here where we see someone trying to put in a screw with a hammer and try to put in a nail with a wrench. And as we know, that is not the optimized approach for success. And I approach patient management in the exact same way. We really want to find the right treatment for the right patient, and also just as importantly, at the right time. So coming back to my second and third question for the group, what do you do when you get a mosquito bite? And what about when you stub your toe? And speaking for myself, I find myself slapping or rubbing or putting some aloe vera when I get a mosquito bite. And when I stub my toe, I'm actually rubbing against the toe. And I'm sure other people have similar experiences. So what are we doing here? Well, you're actually activating the gate control theory, and you've been doing this all along. So what is the gate control theory? Well, it's the act of using a different input to override an unfavorable input. And the goal is ultimately to transform the endpoint. And I want to repeat this again. We're using a different type of input to override something that's less desirable as an input to ultimately change the outcome of what we actually process. So if someone experiences a noxious or painful stimuli, the application of non-noxious stimulus can help activate the gate control mechanism and reduce the pain. So if the gate is open, pain signals pass through. And if the gate is closed, the pain signals will be restricted from passing through. And this is a very key point that I want to make, so I'll repeat it again. If the gate is closed, then pain signals will not be able to pass through. And if the gate is open, then pain signals will be able to pass through. And this is a diagram that shows it on a more molecular level. So the C fibers here are the pain fibers, or a class of pain fibers that are commonly found. A beta fibers are non-pain fibers that detect different types of sensory input. And we have inhibitory neurons and projection neurons that then propagate that signal along the nerve. So when we have a painful stimuli without any other input, we actually have an open gate because the painful signal transmits through the C fibers, hits the projection neuron, and propagates forward. Now, let's take a look at what happens when we can close a gate with the gate control theory. Well, we still have painful stimuli going through the C fibers and going to the projection neuron, but we're actually able to stop the pain from propagating. And why does that happen? Well, we can use things such as the A beta fibers to then cause stimulation of the inhibitory interneurons to then block the projection neuron from firing off those signals. And we can also directly impact these projection neurons to also block the pain signals to come out. So really, these signals here are outcompeting these signals from the C fibers. And that's the fundamental approach to gate control theory. So how do we make gate control theory work for us? Well, we can activate the gate control theory at the level of the peripheral nerve, the spinal cord, as well as the brain. So again, when we have a sensory input, it goes along the peripheral nerves to the spinal cord and then up to the brain where it does higher level functioning and processing. So at the level of the peripheral nerve, we can do things like physical therapy and occupational therapy, where they can implement techniques like desensitization therapy. There's also radio frequency ablation, as well as peripheral nerve stimulation. At the level of the spinal cord, we can do spinal cord stimulation or dorsal root ganglion stimulation. And at the level of the brain, we can actually implement pain psychology techniques to modify our thoughts and our emotions. And there are also advanced techniques such as cortical stimulation as well as deep brain stimulation. And we'll briefly touch upon each of those classes. So, can we make gate control theory work for us? Well, yes. The short of it is yes. And patient selection is key. And just because we can do something doesn't mean we should, because everything has its own set of risks and benefits. And we always want to keep the global picture and goal in mind. And there needs to be meaningful functional, psychological, and symptomatic improvement before we decide to proceed with any of these modalities. So this is a very important slide, and I'm very appreciative of our pain psychology colleagues here at Stanford because they do a fantastic job of using a psychological approach to the gate control theory. So let's talk about opening of the gate, meaning the pain transmission is able to pass through. Well, if we have physical degeneration or medical pathology or the absence of motion, such as stasis, these are all things that allow pain to pass through. From an emotional standpoint, stress, anxiety, depression, and anger are all things that can cause the door to remain open for pain to pass through. Behaviorally, inactivity or overactivity can also leave the door open for pain signals. And from a social standpoint, if someone has poor social support or they live in isolation without interacting, that is also another risk factor for an open gate. And our thoughts are extremely powerful. If someone tends to fixate on their pain or even catastrophize their pain, they tend to have higher levels of pain when they're functioning at a cognitive level because they're allowing these pain signals from passing through. Now, let's see what we can do to close the gate from a psychological standpoint. Well, let's briefly touch over the physical aspects. Exercise, medications, and procedures are all options to help close the gate. Emotionally, relaxation techniques can be vital to one's wellness when they have a pain flare-up. Behaviorally, the act of pacing and really being mindful of how you're carrying out activities can also limit the amount of pain that you experience on a day-to-day basis. And socially, if someone has positive support networks or are involved in their communities, they tend to have lower levels of pain. And your thoughts, again, are extremely powerful. If you're able to distract yourself when you're having a painful episode, or if you're able to rationalize what's going on, you're more likely to process pain at a lower level. So these are all just some of the many tools that we can utilize from a pain psychology standpoint to use the gate control theory to take care of chronic pain. Now we're going to talk about neuromodulation, which is one of the items that I'm most excited about in our pain management space. So what is it? Well, this is really to treat chronic pain by modifying the activity of the nervous system. And the technology acts directly on the nerves. It alters or modulates nerve activity by delivering electrical impulses directly to a target area. So the goal is to train your pain pathway to process abnormal conduction pathways differently. And what I love about it is that the interventions are reversible. And on the bottom here are a couple different devices that we'll briefly go over that takes advantage of neuromodulation, the gate control theory, to take care of pain. And here's a brief history. Well, did you know that neuromodulation actually dates all the way back to 15 AD? Scribonius actually utilized the torpedo fish, and the torpedo fish is an animal that can actually deliver electrical impulses. And what Scribonius found was that by putting the torpedo fishes on wounded warriors, the wounded warriors were able to get electrical impulses, which then decreased the amount of pain that they had. In 1965, Milzak and Wall actually created or came up with the theory of the gate control. And what they found was monumental to the field of neuromodulation because it is the backbone of everything that we do in this space. And Mortimer and Shilley in 1967 produced the first dorsal column stimulator. And Tsubokawa in 1991 created the first motor cortex stimulator. So, what are some of the neuromodulation options? Well, let's start with the over-the-counter option, and that's the transcutaneous electrical nerve stimulation, also known as a TENS unit. And this is a non-invasive neuromodulation technique that uses low-intensity electrical currents through the electrodes placed on the skin. And the electrical impulses can stimulate the nerves and help relieve pain. Another option would be peripheral nerve stimulation, and this is treatment of the peripheral nerve with electrical impulses. And this is particularly helpful and most impactful in patients who have pain in a very distinct peripheral nerve distribution. And the different treatment options as far as stimulating these nerves are: one, radiofrequency ablation, which is a spot treatment of peripheral nerve with electrical impulses. Number two is a temporary peripheral nerve stimulator, where we implant temporary microwires near the nerves to treat for a predetermined duration with an external pulse generator. And of course, there are permanent peripheral nerve stimulators, and these are minimally invasive implantable microwires with an internal or external pulse generator. And this sometimes requires a short-term trial with temporary peripheral nerve stimulator. Next is dorsal column stimulator, also known as spinal cord stimulator. And this is treatment of the sensory transmission pathways at the level of the spinal cord with electrical impulses. So the microwires are placed outside of the protective layers of the spinal cord in the epidural space. So even though the term is spinal cord stimulators, we are multiple layers outside of the protective layers of the spinal cord. So here we can see the spinal cord. Here's the dura, which is the protective layer. And here's the epidural space where the microwires can be placed. And what it feels like is it can either be tonic or paresthesia-free. In other words, you can have a low pulsating sensation, or you can have a setting where the frequency is high enough where you actually don't feel anything. And prior to an implant, this typically involves a 3 to 7 day trial with the temporary microwires before implantation. So you get to try the system before committing to it. And the implants are performed using minimally invasive or traditional techniques. And the implantable system can involve rechargeable batteries or non-rechargeable batteries. Dorsal root ganglion stimulator is another option that we have at the level of the spinal cord. It's a treatment to the sensory transmission pathways of the nerve roots as they are about to enter the spinal cord with electrical impulses. So if you look at the upper right corner here, here's the neuroforamen, and the spinal cord is down the middle, deep inside. So we target the nerves right before they converge at the spinal cord here. So again, the microwires are placed outside of the protective layers of the spinal cord and into the neuroforamen. And it also typically involves a 3 to 7 day trial with temporary microwires before implantation. And the implants are performed using minimally invasive or traditional surgical techniques. And this is a multifidized stimulator. And this is specifically for low back pain that has components of muscular atrophy. And what we do is we actually activate the multifidi muscles to strengthen the atrophied muscles. And the microwires are placed outside of the vertebrae and the spinal cord. So this is very superficial. And this treatment does not require trial, and the implants are performed using a minimally invasive technique as well. Here is a vagus nerve stimulator. This is something that's newer to the space where we target resistant headaches, seizures, and depression. And the microwires are placed next to or wrapped around the vagus nerve. And the implants are performed using minimally invasive surgical techniques as well. And here is the deep brain stimulator. And this is treatment of different regions of the brain to target resistant functional movement disorders, such as Parkinson's disease or severe painful symptoms. And the microwires are placed into the brain at specific points. And these implants are performed by neurosurgeons. So, in summary, what is the purpose of neuromodulation? Well, we want to use it in conjunction with physical therapy, psychology, and/or medications to help restore function. We want to treat chronic pain by modifying the activity of the nervous system in a very targeted fashion. And we want to train the pain pathways to process abnormal conduction pathways differently. So again, we don't look at neuromodulation as a cure for your pain. Neuromodulation is a way to change how your nervous system processes pain and ultimately allow you to do all the other techniques that we talked about as part of the 4 legs of a chair to help you optimize your functionality and your well-being. So some of the considerations for neuromodulation. Well, number one, we want to make sure that a patient is a good fit from a psychological standpoint. And we are very fortunate to have pain psychologists that can help us make this determination. And we really want to make sure if the patient understands the risks and the benefits of the procedure. And we also want to see if the patient has a support system in place and if there are any psychological concerns. We also want to know where the issue is. Is the problem at the level of the peripheral nerve, spinal cord, or the brain? And sometimes it can be a mixed etiology where it can happen at different levels. And are there any other medical concerns? Even though sometimes we can use these treatments to treat a painful nerve condition, it may not be the best fit when someone has a more severe symptoms that they're trying to work up. And also, you need to make sure that your physician feels that this is a good fit. If you're my own family member, I would tell you, I would not go through with a treatment option that your physician is not comfortable with. Because if your physician is not comfortable with this treatment option, it means that there's a lower likelihood of success. And we really should be reserving some of these advanced neuromodulation techniques for when patients have tried other options that are less invasive. And what are the benefits of using neuromodulation and gait control theory? Well, number one, it offers long-term relief. Other treatment options we have in our pain space only offers short-term relief, although sometimes we are fortunate where they are longer lasting. Neuromodulation can sustain pain reduction and functional improvements over time. And this can ultimately help our patients engage in daily activities, improve sleep, and enhance their overall well-being. Additionally, neuromodulation gait control theory has had a huge expansion of treatment options. We've been able to treat various chronic pain conditions as well as neurological conditions with neuromodulation. And it can be used in isolation or in combination with other therapies using a multimodal approach. And this flexibility allows your treatment team to really tailor the plans specific to the needs and preferences of each individual. Additionally, this is a treatment option that's reversible. Therapy can always be turned off when necessary, and we can always remove the implants without causing permanent damages to the nervous system. Additionally, this is a treatment option where the parameters of stimulation can actually be adjusted to tailor to one's unique needs, because we know that everyone has different requirements. So we can adjust the frequency, intensity, and the duration and customize that to the individual. Furthermore, this is a non-drug treatment option. In using the pain psychology gait control theory tools, as well as neuromodulation, we can provide non-pharmacologic treatment approach to chronic pain. And this ultimately reduces reliance on medications. And this is an excellent alternative for patients who may not be able to tolerate, or perhaps they're not benefiting from their traditional pharmacologic therapy. The other thing that I love about neuromodulation and using the gait control theory is that it's a targeted therapy. Neuromodulation really zones in on specific areas of the body or the nervous system, and that allows for precision pain modulation, and also decreases systemic side effects that one would otherwise get from medications. So I want to come back to this image. Do you know of anyone who has a hearing aid, a pacemaker, an insulin pump, or hardware? And the reason why this is pertinent is because 1 in 10 US citizens will have an electronic device implanted into their bodies during their lifetimes. So what does this mean? This means that we're already in the future where we're using technology to our advantage. And in the right patient, we can really use neuromodulation, the gait control theory, to target chronic pain and help facilitate physical therapy, improve psychological wellness, and reduce medications. And I want to highlight this slide because it is, again, one of the most important image I want all of my pain patients to understand. And that's the 4 Ps of comprehensive pain care. It's the 4 legs of a chair. And there's physical therapy, psychology, procedures, and pharmaceuticals. And the beauty of the interventional pain space, as well as the chronic pain management space, is that we have different tools at our disposal. And every leg is crucial for long-term stability. So at a good pain institution, they will be able to help manage your pain from a multi-variable approach to ensure that every different level is able to be targeted, or at least able to be optimized or trialed. And from a procedural standpoint, neuromodulation is only one aspect of one leg of the chair. So even though this is a fantastic breakthrough technology that we have in our space, this is one of the many aspects of therapies that we offer in interventional pain and chronic pain management. So it's important to consult with their healthcare team to determine whether using gait control theory for a particular condition is the right fit. And you also want to talk about the potential risks and benefits based off of your individual circumstance. And I just want to highlight, there is a multitude of tools in the pain management space. And we want to make sure that we're using the right tools for the right job in the right way. And we want to make sure we're using the right intervention for the right patient at the right time. So again, the future is already here, and we really want to use gate control theory to our advantage. And neuromodulation is a form of gate control theory that can enhance the 4 P's of comprehensive pain care. And at the bottom of this slide, I just want to highlight some of the key themes. There are already many devices that we utilize to our advantage to help treat pain and different conditions in the healthcare space. We talked about the 4 legs of a chair for comprehensive pain care. We also talked about using the right tools, and we talked about the different pain pathways and where we can target the pain pathway at different points. And we talked about using pain psychology, unlocking parts of our brain in order to help modify painful impulses. And of course, we talked about neuromodulation. And this is just an image of me being very excited about our space, because this is one treatment modality that I truly believe in when the right patient is selected. And with that, that is the end of my presentation. I want to thank everyone for listening with me. Here are some additional resources that